Good evening. I'm Psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now going on its 28th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, you may call me in the Fort Wayne area by dialing 969-2720, or if you're calling long distance, you may dial toll-free at 866-969-2720. And we're also available live on YouTube. Now, on a fairly regular basis, every Monday night, we are broadcasting live from our PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email I recently received. It reads, Dear Dr. Fawver, I've been suffering from anxiety and insomnia since before my husband's death 11 weeks ago. I started 10 milligrams of Trintellix last week, but that left me staggering and unable to walk. I now take 5 milligrams of Trintellix at bedtime and a half milligram of Ativan 3 times a day. Is it safe to increase the Trintellix dosage? Could either of these medications affect my eyesight? Trintellix and Ativan are entirely different medications. They don't usually affect the eyesight, but as I always tell people, if you start a medication and all of a sudden you notice some unusual changes in your physical well-being or anything at all for that matter, it might be due to the medication itself. Trintellix is a medication that, like any antidepressant medication, can dilate the pupils, and if you're prone to having glaucoma, such that you might have blurred vision or a painful eyeball, your pressure in your eyeball is too high, any antidepressant medication can dilate the pupils and give you a worsening glaucoma. If the Trintellix is dilating your pupils, you might notice you have a visual change there, because if you dilate the pupils, you might have difficulty with being able to read things or see things at a distance either way. So it could be that Trintellix giving you a little bit of difficulty with eyesight. Trintellix doesn't usually make you unsteady on your feet, whereas lorazepam or Ativan does. And especially when somebody's grieving, usually you don't want to be taking Ativan or lorazepam for a long period of time, because it can actually complicate the grieving process. The good thing is you're only taking a half milligram of Ativan 3 times a day. It's a low amount, but it's enough to make anybody over 55 years of age especially have problems with unsteadiness. So that's probably the medication giving you the unsteadiness between the Trintellix and the Ativan. Talk it over with your primary care clinician or your prescribing clinician concerning the increase in the dosage of Trintellix. About 1 out of 6 people will stay on Trintellix at 5 milligrams a day. 3 out of 4 people will get up to 10 milligrams a day, and then other people will go further to 20 milligrams a day. Everybody's a little bit different. Sometimes we can determine based on a person's genetics if they're going to get by on a lower dosage or a higher dosage, but most people do go to 10 milligrams a day. And I'd suggest trying to back off lorazepam, but talk that over with your clinician. Thanks for your email. Let's go to our first caller. Hello, Peter. Welcome to Matters of the Mind. Peter, you had asked, logically speaking, why can't we as a society find common ground on conflict? Peter, you could also be known as Plato, because that's what Plato thought. Plato thought if we just used logic, we could all pretty much agree on the best decisions politically and as a society. The problem is, Plato didn't take into consideration, it's part of the brain, it's in the inside part. Here's the front of the brain, here's the inside part. Part of the brain called the ventral medial prefrontal cortex is right inside here. The ventral medial prefrontal cortex will filter information coming into the brain and interpret what the brain is perceiving based on your overall emotional state. In other words, when you receive information and you're receiving logical information, it has to go through an emotional filter. So, Peter, what you'll notice is that people will have certain beliefs, often with a emotional overtone associated with those beliefs. And it's called cognitive dissonance, where you will have cognitive dissonance where you'll have a particular ingrained belief, and then you might have outside information coming in that might conflict with that belief. And it causes a lot of anxiety because you're pretty set in your ways with your beliefs based on your emotional state. So you'll have this emotional valence that will influence what you're perceiving with the information coming around you. We see this sometimes with disorders such as bipolar mania, even with schizophrenia and with psychosis, where, especially with bipolar mania, for instance, if you're really hyped up and your thoughts are racing a mile a minute, you might be be pulling in information that can be interpreted differently than you would interpret it if you were of a normal mood. Same with depression. We'll hear about people being very depressed, so they are more pessimistic on things. And again, they're bringing in information that they're interpreting from an emotional standpoint and thereby not using logic to make the best decisions. Plato thought we could pretty much run our society on logic if we just had all the information in front of us, but there's a lot of emotional overtone with how we take in information. Peter, thanks for your call. Let's go to our next caller. Hello, Shannon. Welcome to Matters of the Mind. Shannon, you want to know, what are the benefits and side effects of Cobenfy for patients with schizophrenia, and how can your doctor help you with identifying and setting goals in your treatment plan? Well, in terms of setting goals for your treatment plan, I think that's something that you need to identify. How would you want to feel better? I ask every patient of these kind of questions. What are your 3 main goals of treatment? How would you want to feel better overall? Secondly, what would be a game changer in you're not wanting to take medication? What would be the reasons for which you would not want to take medication? So we get that on the table right off the bat. So it's a matter of you partnering with your clinician to try to identify what your goals of treatment should be and will be. If you have your clinician just tell you what the goals might be, they might not align with your beliefs. So with that being said, Cobenfy. Cobenfy is a medication that has been manufactured and researched by Bristol Myers Squibb. Came out about a year ago. It's an entirely revolutionary medication for schizophrenia, and we've heard outstanding results from it. It's not affecting dopamine directly. It's not blocking dopamine, as all of our antipsychotic medications have done for the past 6 decades, 7 decades now. My goodness, it goes back like 70 years. We've used antipsychotic medications, starting with Thorazine, that block dopamine. And that's how antipsychotic medications work. If you block dopamine, you will block this excessive dopamine transmission in the limbic system, also known as the temporal lobe here. But the problem with schizophrenia, you have too much dopamine transmission here, but you have not enough dopamine transmission in the frontal lobe. The frontal lobe is where you think, and that's where you concentrate. So the atypical antipsychotic medications that were developed starting with clozapine or Clozaril in 1991, they started coming out, I believe. It's been a while. But clozapine blocked dopamine here, but it blocked serotonin transmission in the front part of the brain. Blocking serotonin type 2A transmission in the front part of the brain increases dopamine in the front part of the brain. So we had some help in that way, but they still have their drawbacks with the atypical antipsychotic medications blocking dopamine in the limbic system and increasing dopamine in the frontal lobe. So Cobenfy is a medication that was researched for Alzheimer's dementia years ago by Lilly, which is out of Indianapolis. Lilly researched the active ingredient in Cobenfy for Alzheimer's dementia because it was increasing transmission of muscarinic receptor activity. Muscarinic receptors, if stimulated, will increase acetylcholine. If you increase acetylcholine, you indirectly decrease dopamine and thereby decrease dopamine in the limbic system where it's overactive with schizophrenia. But if you increase the muscarinic transmission and increase acetylcholine, especially in the frontal part of the brain, you will thereby improve concentration, motivation, and get up and go. So Cobenfy is a medication that will specifically stimulate 2 of the 5 different muscarinic receptors. It stimulates muscarinic receptor number 1 and number 4. If you stimulate those receptors, you can improve concentration, memory, and indirectly decrease dopamine and decrease hallucinations and delusions and the problems that we often hear about with schizophrenia. So why wasn't the active ingredient in Cobenfy approved for or researched further for dementia? It's because when people took that particular drug, they had nausea and diarrhea, because if you increase acetylcholine, it goes to the gut, it'll fire up the gut, it'll cause you to have bladder problems where you have difficulty with bladder retention, you'll have difficulty or bladder difficulty with incontinence. You can also have difficulty with a slow heart rate if you will tend to tend to stimulate the muscarinic receptors. So what they did is they added a second medication in Cobenfy, and that second medication in the body itself will block acetylcholine transmission. That offsets the side effects that people have on their heart and their gut and their bladder. So for that reason, Cobenfy is more tolerable, and it was found to be a really good medication for schizophrenia. Might someday be used for Alzheimer's dementia, but it wasn't tolerable for Alzheimer's dementia. For schizophrenia, it's much more tolerable. It's taken twice a day with or without food, and gradually titrated for people. But it's been a really nice medication for a lot of people with schizophrenia, with the biggest side effects being nausea and diarrhea that are perpetually there. And if you have any difficulty with bladder retention, having any difficulty with going to the restroom and urinating, that can be a problem for people who are on Cobenfy. But that's all side effect. The side effects are dose related. Thanks for your call. Let's go to our next caller. Hello, Tiffany. Welcome to Matters of the Mind. Tiffany, you had mentioned that you've been slowly weaning off Effexor, also known as venlafaxine, for 3 months, but you can't go for more than 24 hours without having withdrawal symptoms like a fuzzy head and numb face. So you then cave in and take the medication. Is there something you can do to help you get over that? Are you doing the right things? Effexor or venlafaxine is very difficult to taper off. We have to do so very slowly, and you've been hanging in there for 3 months trying to do it. Venlafaxine or Effexor is a medication that increases transmission of norepinephrine and serotonin, but the problem is twofold. Number one, it doesn't last very long in the system, and number two, it's only about 30% protein bound, so it doesn't hang on to the proteins. In other words, it just gets in the body and gets out pretty quickly, whereas a lot of medications are over 90% protein bound, so they kind of stick around for a while. So they hang around on the protein. Effexor gets in and out so fast, it can give you what's more accurately known as discontinuation symptoms. It's not considered to be true withdrawal, it's more discontinuation symptoms. So when you stop venlafaxine abruptly, you can have zings and zaps in your scalp, in your hands, your feet. You can feel very dizzy. And when they had their immediate release venlafaxine, which was first available in the 1990s, people would go to the emergency room if they missed a couple doses because they thought they were having a stroke. They felt terrible. So then the XR version of Effexor came out, and now we have venlafaxine in the generic version. We have venlafaxine XR. It's an extended release version. It's in a capsule, it has beads in it, and it slowly releases over the course of a whole day. What we often have to do is we will have people go down very, very slowly, 37.5 milligram increments at a time, and sometimes it will be over the course of several weeks. Well, you're already doing that. My goodness, you've been trying to do that for 3 months. So what's plan B? Sometimes we'll add a little bit of a medication called fluoxetine, also known as Prozac. Prozac stays in the system for days, and Prozac can sometimes balance out or dampen down the withdrawal that you're having from venlafaxine. We hate to add a second medication to a first one when you're trying to get off the first one to begin with, but in the case of fluoxetine, sometimes that will dampen it down. But the key will be to slowly taper off piece by piece by piece off of the venlafaxine and get that dosage down as low as you can. The lowest dosage of venlafaxine is 25 milligrams, so you can go really slowly in terms of coming down off of it. But if you need something to be added to it to dampen some of the discontinuation symptoms, that would be fluoxetine. 10 milligrams is often enough just to hold you over. You take that for 2 or 3 weeks as you're coming off the venlafaxine itself. But it's a real phenomenon, and it's particularly prone to occur of the antidepressants with venlafaxine, also known as Effexor, and Paxil, also known as paroxetine. Paxil or paroxetine is an entirely different phenomenon when it gets out of your system, but both of those can give you those discontinuation symptoms. Thanks for your call. Let's go to our next caller. Hello, Kim. Welcome to Matters of the Mind. Kim, you mentioned that you can smell and taste the food that you're dreaming about. Is that possible to have a dream that intense? It really is. You know, you can have sensory input when you're having dreams. People will have the same phenomenon where they have an increased sensation of taste and smell when they're having migraines, and not uncommonly when they're having seizures. So what's the commonality there? It's all coming from the temporal lobe here, the memory center, with migraines, with seizures, and with intense dreams. Your temporal lobe's getting really fired up here. And actually the sense of smell is one of the most distinct memories that we will ingrain if you have a particular smell from the past that was particularly meaningful for you, whether it was related to trauma, a good experience, or whatever, is a particularly meaningful experience for you. That sense of smell can be easily triggered later on, and in the case of dreams, that also can occur. And as you can imagine, smell, taste, touch, sound, and sight, those are all our sensory inputs. Smell and taste often go hand in hand. So you might just be prone to being able to do that with intense dreams. Doesn't mean it's pathological at all, but that is a not uncommon phenomenon. Thanks for your call. Let's go to our next caller. Hello, Drew. Welcome to Matters of the Mind. You want to know, how do you deal with your quick temper when you're in conflict, and how do you deal with your anger during small disagreements without feeling that you're going to be losing your temper? Well, there's a lot of things going on there, Drew. Number one, try to identify what gets your temper going. Many people will have difficulty with dealing with their anger when they feel like they've been personally slighted and they feel as if their honor has been offended. So somebody has challenged them, and this is why in the southern states, especially over 50 or 60 years ago, there was a higher murder rate in the southern states, because in the southern states, traditionally, going all the way back to the 1800s, honor was very, very important. So if somebody offended you or your loved one, you were expected to retaliate, and they would have duels. And as time went on, okay, they didn't have duels so much anymore, but they would tend to fight if they felt like their honor had been offended in any way. So number one, consider the source of your anger, why you're getting angry. Secondly, people will often feel like they're getting angry because they've been victimized. And again, it goes back to somebody else influencing your emotions. So whether you feel like your sense of honor has been betrayed or you've been victimized, it all comes from an outside source. So the first thing I would suggest you do if you're having trouble with anger and conflict is try to identify, why are you getting so upset about things? Why are you allowing other people to set your emotional tone? Because that's what's often happening. Now, if you have an underlying pathological condition where you're having trouble with anger, okay, we get that. People with bipolar disorder, where they're having manic episodes, will often have anger as associated with the bipolar episodes. Men especially can get really angry when they get depressed. So if you're noticing you're quick to get angry because you're depressed, especially if you're a man, that can be a factor. People with ADHD, there's certain types of ADHD where people are going to be more prone to being more impulsive hyperactivity, and they too can have a quick trigger on their anger itself. We can treat those kind of conditions, but I'd go back to the original source of your anger. Is you're getting angry because you feel like you've personally been offended by somebody, or do you feel like you're being victimized by somebody else? Those kinds of angers can be alleviated by getting your perspective changed on your personal responsibility, as opposed to having other people dictate what your emotional tone will be. Thanks for your call. Let's go to our next caller. Hello, David. Welcome to Matters of Mind. David, you want to know, what are some thoughts on memory and brain supplements, and what's the safety issues and measures when using melatonin? And can I recommend both? Melatonin's been around for a long time, very safe to use, and you can use it long term. Typically, people don't need to use more than 3 milligrams or even 5 milligrams, which is a common dosage over the counter. So 5 milligrams of melatonin is often plenty, unless a sleep specialist is recommending that you take 10 or 15 milligrams for whatever reason. But many people who take 10 and 15 milligrams of melatonin will have nightmares, and they'll have more problems with it. Taking a higher and higher amount of melatonin will not give you a deeper or better or more efficient sleep. Usually 3 to 5 milligrams is all you need at bedtime. You take it about 30 minutes before you intend to go to bed. Melatonin is like a puff of smoke. It's there very briefly, and then it gets metabolized very quickly. Melatonin is doing one thing. It's giving your brain a signal to go to sleep. Our brain naturally will do that as we get exposed to darkness at nighttime. So as you're exposed to darkness, the melatonin levels go up. That's why you need to be careful with any screen time at nighttime, because that bright screen on your computer or your cell phone is going to keep your brain awake. So melatonin will be suppressed with bright light. But melatonin is the vampire hormone in the sense that it gets up when it gets dark outside. That's why it's called the vampire hormone. So melatonin can be safely used long term, and it's often used for younger people, even adolescents, who have a sleep-wake cycle that's a little bit delayed, in the sense they like to go to bed later at night and they like to sleep in longer in the morning. If you can get them to bed a little bit earlier, especially during the school year, that can be helpful with 3 to 5 milligrams at bedtime of melatonin. Fairly safe to use. Now, what supplements can you use for memory or decreasing Alzheimer's, dementia for that matter? I wouldn't recommend any based on what we know right now. The supplements I highly recommend to a lot of people on a day-to-day basis will be the possibility of using vitamin D on a regular basis, and magnesium. Magnesium glycinate is very well absorbed, so magnesium 400 milligrams at bedtime can be very, very helpful if people were to check their magnesium levels, especially if they're under chronic stress, if they're depressed, if they use alcohol. their magnesium levels will often be lower than expected. If your magnesium level is lower than expected, it can often give you difficulty with fatigue and even feeling more depressed and having difficulty with concentration. So a magnesium supplement, vitamin D can often be helpful. There are other supplements that you can ask your primary care clinician what he or she might take. I always tell people, ask their clinicians what they take and see if you can get any ideas from that. But supplements specifically for dementia or to prevent dementia and improve your memory, I know there's been a lot of them touted, but they just don't seem to have really good placebo-controlled outcomes that I could certainly recommend. I remember back in the 1990s, a real popular supplement was ginseng. Ginseng, do you ever hear anybody talking about using ginseng anymore? No, it was a fad back in the 1990s. It was thought that ginseng would help with memory. It really didn't. It didn't play out so much. So you rarely hear about ginseng anymore. So what can you do for your memory? What can you do to enhance it without taking supplements for that matter? Well, if you think about helping with your memory, number one, you want to exercise. Exercising any way, anyhow, whether it be resistance training, whether it be aerobic exercising. Exercising increases two chemicals in the brain at the same time, GABA and glutamate. In doing so, it can improve your memory and retain your memory over the course of time. So exercise, number one. Number two is maintain socialization. People who get more socially isolated have a lot of difficulty with having memory problems, but you've got to maintain social activity. You've got to exchange ideas with people, keep your brain active with socialization overall. What else could you do? Number three, get good sleep. You have to get good sleep. I mentioned melatonin, you bet. If melatonin is necessary to get you to sleep, get good sleep. Try to turn off your cell phone, your television within an hour, your computer within an hour of going to bed. Try to read something out of a paper book. Yes, they still exist, but something that's not going to be a bright light. Sleep is exceptionally important for older adults to retain their memories overall. Fourthly, people talked about puzzles in the past. Puzzles used to be thought to be really helpful to retain your memory, but then it was found that with puzzles, they are basically helping you do puzzles. So the puzzles themselves won't help with your memory, but what can help you with your memory is trying to learn new things in general. Learn new things, whether it be political, different ideologies, keeping up with the news, learning a new language, reading about things you hadn't previously learned. Reading new things can be very, very important for a lot of people. So those are the main means by which I would suggest you try to enhance your memory. And bottom line is keep your blood sugar, your lipids, your blood sugar, your lipids, and your blood pressure all in really good control to be able to preserve your memory as we get older. Thanks for your call. Let's go to our next caller. Hello, Nicholas. Welcome to Matters of the Mind.
Oh.
Hi, Nicholas.
Could a massive stroke at a very young age look as schizophrenia later in life?
It's hard to say, Nicholas. A massive stroke at a young age could cause you to have irritability, could cause you to have moodiness. Schizophrenia is a condition where you would specifically have the ability to hear voices other people can't hear. You'd have fixed false beliefs, having delusions. You'd have trouble with processing information, processing thoughts. You'd have trouble with being able to socialize and interact with other people. So that massive stroke, quite frankly, if I was to speculate, it would have to be in the left front side of the brain, especially affecting this area of the brain called the arcuate fasciculus. The arcuate fasciculus goes from the front part of the brain to the back part of the brain. It goes from the talking part of the brain to the hearing part of the brain. People with schizophrenia will have a disruption of that band of tissue called the arcuate fasciculus, and thereby, when they have thoughts, they will inadvertently interpret those thoughts as being a voice. So I could speculate that kind of a stroke could cause you to have psychotic-like symptoms later on, but quite frankly, Nicholas, when people have a stroke early in life, the symptoms that will persist later on will be difficulty with irritability, moodiness, concentration, focus, and maybe that could be interpreted as being psychotic symptoms to some degree, but I think it all comes down to what kind of symptoms people would have. But if you had that stroke in a particular place, maybe you could have psychotic symptoms, but it's not very common for that to occur. Usually it's more moodiness and irritability and difficulty with concentration that people will experience, Nicholas. Nicholas, thanks for your call. Let's go to our last email question. Our last email question reads, Dear Dr. Fawver, can long-term psychiatric medication cause neurological problems? I've been on Effexor, lamotrigine, Prazosin, and Auvelity for a while. They are working, but I'm worried about long-term effects. Those particular medications would not give you long-term neurological conditions, but of the ones you mentioned, Auvelity and Effexor do have some overlapping effects on serotonin. Auvelity's main mechanism is that on glutamate, but it has a little bit of a serotonin effect. My only concern with that combination is it could potentially give you some serotonin toxicity symptoms such as diarrhea, headache, fast heartbeat, sweatiness, and nausea. So be aware of that. Neurologically, those would not give you tardive dyskinesia or any kind of antipsychotic-like long-term effects. Thanks for your email. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm Psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS Fort Wayne, now available on YouTube. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.